Okay, good afternoon, everyone. I'm going to figure out how close I need to stand to this microphone without blowing out everyone's ears. Thank you so much for being with us here today in this room, but in the rooms for the last 2 days. As someone who has worked in the area of health equity and culturally and linguistically appropriate services specifically for more than 20 years now, I am just in awe of the conversations that have been had the last 2 days. I'm thrilled to be spending this session with you all. I literally just get goosebumps because when I started doing this work 20 plus years ago, and people would say, "So what do you do for a living?" And then I'd say, "I teach people how to be more culturally and linguistically appropriate." And they'd go, "What?" And so I was like, the cocktail party answer is I teach people how to play well with others. But to be in a room and to be in these rooms, to have these conversations these last few days, and everyone knows about health equity. You don't have to explain it. You don't have to talk about the fact that making sure that things are culturally and linguistically appropriate, like it's not even a second thought. People get it. And it's just, I'm just in awe. So again, thank you. My name is Darcy Graves, and I am a technical director within the CMS Office of Minority Health. You'll hear a little bit about why we stress the CMS portion of that when Leander and I talk in a little bit. But I will be serving as your moderator, but also as one of the panelists. If anyone understands wearing multiple hats, it's the individuals who work in cultural and linguistic competency in health equity, because we're always having to do many things and be in many rooms. I am joined by a number of esteemed colleagues today, whom I will introduce in just a moment. For a little bit of housekeeping, while we would love to do Q&A at the end, I'm not 100% sure how all of the timing will work out, but I can guarantee that we will make sure that you all have a chance to connect with our speakers today. We can share email addresses and those sorts of things, but are also happy to entertain questions as much as possible. All of our contact information is in the different slide decks, so that you should be able to reach out that way as well. Also, as a reminder, the closing remarks for this conference are going to be live streamed into this room. So even when we have taken our bows, please remain seated. And Dr. LaShawn McGeever will visit us via live stream. She'll be beamed in. We're very fancy. So there we go. So to ensure we have time for everyone's presentations, because as you might imagine, we all get deeply, deeply passionate about these things. And so we're trying to keep to our times and try to keep to our scripts. But I'm going to do brief introductions now. More expansive bios are also available on the website. So first, and I'm just so tickled by the combination of presentations that we have on this panel. I told them when we pre-met last week, I said, I'm totally geeking out. Like, this is like part of my work at CMS OMH is working with rural health. And so first up, we are going to hear a presentation on targeted rural health education project from the University of North Dakota School of Medicine and Health Sciences. And I love that we're finally combining the words rural with health equity, because we haven't been doing that for very long. And it's so important that we continue to push that envelope. So for this portion, we're going to hear from Kay Miller Temple, who began her health and medical writing career after practicing for 30 years in rural and urban locations as a primary care physician. Her writing focuses on national rural health issues, and she mentors health profession students in health literacy and the use of plain language. Then we'll also have Dr. David Schmitz, a family physician dedicated to medical education and rural health. He is a professor and chair of the Department of Family and Community Medicine at the University of North Dakota of Medicine and Health Sciences, School of Medicine and Health Sciences. So then we're going to pivot and we're going to talk about the national class standards as a framework for advancing language access, health literacy, and the provision of culturally and linguistically appropriate services. For this portion, you'll hear from a friend and colleague, Leandra Olson, who serves on the policy team lead for the HHS Office of Minority Health. And since 2015, she has worked at HHS in a variety of policy roles dedicated to improving health equity and addressing health disparities, including for maternal and child health, language access, global health, and the health workforce. And you will also hear from me, Darcy Graves. I have been with CMS Office of Minority Health since 2015, helping to lead and support a variety of enterprise-level activities, including the development of the CMS Framework for Health Equity, which you may have heard a little bit about the last 2 days, as well as, and here comes the rural tie, as well as the CMS Framework for Advancing Healthcare in Rural, Tribal, and Geographically Isolated Communities. Prior to joining CMS, I was a contractor for the HHS Office of Minority Health, where I helped lead initiatives, including the enhancement of the national class standards and the development of the 2013 HHS Language Access Plan. Our last presentation is focused on community partnerships and data advocacy for cultural and linguistic competence in developmental disabilities. And again, so glad that we are bringing that lens to bear in this work. For this presentation, we'll be hearing from Dr. Hira Mir, who is the Chief Diversity Officer for the New York State Office for People with Developmental Disabilities. Dr. Mir works to advance the policies and practices of cultural and linguistic competence into all components of the OPWDD system of supports and services for people with developmental disabilities and their families. And lastly, Regina Rodriguez Cisneros serves as the Director of Equity Initiatives and System Innovations at the National Association of State Directors of Development Disability Services. She is an alum of the Georgetown University's National Center for Cultural Competence Leadership Institute, as well as an alum of the Colorado John F. Kennedy LEND program, Colorado native, and family advocate. And with that, I will now turn the microphone over to Kay and David.
Well, thank you for those introductions, and we're really excited about the sessions and the time we have to share today. I'm Dr. David Schmitz, and I'm a country doctor at heart. I am wearing a suit, coat, and tie today, which is a little less functional for that job, but really excited to be here, and thank you, Kay, for joining me.
I'm Kay Miller Temple, and I am a white female. I have black hair with lots of gray that I earned. I have a denim jacket on with a green shirt because that's UND school colors. For those of you who are interested in footwear, I pulled out my most comfortable footwear out of my closet, which are low-heeled, square-toed cowboy boots. And with that, we'll get started.
We've got just a few moments really to tell you a little bit about a project we've been working on together for several years, known as the Targeted Rural Health Education Project, or what I like to call the TREE Project, and we'll go ahead and get started. I think part of the reason that we're happy to be here with you today is to promote the CMS priorities, and this project is specifically aligned with the CMS Framework for Health Equity 22 through 32, priority number 4, which has to do with language access and also health literacy, in addition to the CMS Rural Health Strategy objective number 4, which also supports collaborating with rural community networks to develop and disseminate easy to understand materials to help rural places, to help and engage our communities, and also to foster the empowerment and engagement of our patients located and our neighbors located in rural areas. You'll hear a little bit more about how our students have been able to do that. In addition, the Office of Disease Prevention and Health Promotion, Health People 2030, has actually made health literacy as a central focus. And that really started, of course, that knowledge of that being a priority was after we had started this project. Yes. But we see a significant amount of alignment that we hope will help to get this audience and others excited about possibly replicating our project. Okay.
And one of the things that we liked about that last priority area alignment is the fact that a goal of that was to get people to talk to friends and family. And we're going to talk to you about how we get that done too. So first, my area is health literacy. So what is health literacy? It is an individual's ability to find, to understand, and to use information to inform their health-related decisions and actions for themselves and others. But health literacy is also tightly linked to the use of plain language. So what's plain language? Plain language is writing and speaking in a common language that all readers and all listeners can understand and remember the first time they either read or hear it.
The Targeted Rural Health Education Project begins with students and learners in mind. We actually began with resident physicians who had finished medical school with this project in the state of Idaho. But since coming to North Dakota, we've worked with not only medical students, but other health professional student learners to really allow them to be in a community-based, enriched sort of dyad, where it's a relationship in both directions. We know that the curriculum really is the community, and so the community is able to help shape the student's experience. And with this project, they're actually able to author a plain language health education article, which can be published, in a local rural newspaper. And so again, the learning objectives have to do with the power of plain language and being able to translate that to learners who otherwise are almost learning a different language in medicine altogether. And also the small n, how one individual's actions can actually have a large scale effect. When we look at the tree-focused health literacy, and we begin to understand the tree's role in providing that plain language articulation, we can begin to look at the use of plain language and how that can really help our stakeholders understand more.
So, why did we choose to use rural newspapers as the focus of this project? And you've heard about internet deserts, brombad deserts, and sometimes the maps don't always match the lived experiences, but one of the reasons is we kind of live that internet connectivity issue. So we work with rural newspapers for that reason, but there's a couple other important reasons that we had chosen rural newspapers. First, the data says we should be using them because news association surveys show that citizens, even in small communities, about 70% of them will get their local newspaper. And other reports demonstrate that rural newspapers are that local voice that speaks the language of that local culture, whether it's the language of the oil fields in northwestern North Dakota, or whether it's the language of our ag families and communities in southeastern part of our state. So I believe that the comment of one of our newspaper association's leaders had summed it up well. He had commented that newspapers are read, reread, clipped, saved. That clipping is taken to clubs, card games, shared in all kinds of settings. It's a natural medium for rural America. And this leader also shared that surveys demonstrate that in rural communities, as opposed to the small communities, 85% of people get a local newspaper. In my home community, that is true. And the other thing that's really pretty remarkable is those that get the newspaper share it with those that don't. Sometimes when those that don't want it, but they'll get it anyway. So another important consideration is that in newspapers, you can get different information conveyed than is available in TV or radio sound bites. So in summary, health information in rural newspapers is discoverable, shareable, and actionable.
And I think when we begin to look at the way our students are interacting in communities, again, the community as the curriculum, when we look at health professionals that are ready and prepared for rural practice, oftentimes it's actually that framework and context that helps us to deliver the best healthcare and the best health information. And so the majority of our learners have actually been medical students, but we have had 2 occupational therapy doctoral students as well participate in this. And we've based much of the content on targeted community health needs assessments. And those are often available publicly. And so the material can not just be something that is for the community, but rather with the community, because the community themselves have developed those health priorities for themselves, and the students can begin to engage the community, and at the same time they're learning these plain language skills. And so when they're writing, again, they've heard about it, they want to do it. Hopefully with the local rural newspaper, this becomes essentially a kitchen table conversation instead of something that might not be as easily discussed. And we found that particularly around mental health issues,
Oh,
that this is a way to actually be able to have newspapers and students and others engaging in important topics for that particular community.
Okay, so let's talk a little bit about the writing process. So for all of the students who partake in or who participate in this, we introduce the project to them with a 30-minute Zoom meeting, review the project, have a Q&A. And because the students have so many competing other things that they've got to be learning to take care of you all sitting in those chairs, we feel like the best way to get this information across to them is to use the evidence-based teaching format of on-demand, need to know, just in time. And that works really well for them. A lot of them too are just, they've got stuff they've got to learn, they've got exams they've got to excel on, so that type of teaching method works well. We also modify a very common writing method, and if any of you in this room are writers, you know about this, don't just tell, you got to show us thing, and we've modified that a little bit, and we've converted it to tell the student why what they're writing isn't working, show the student an example of what will work, and then have the student translate that example into their own writing voice. And this feedback in that fashion provides a writing approach, provides our students with a writing approach with that hands-on experience. It's a hands-on doing kind of thing for them. And this does a really good job of introducing them to health literacy and the use of plain language. And so when the writing mentor and the student feel that the article is ready for publication, we have another layer of review. For those of you who are writers in this audience, you kind of get that you're so close to it, you can't see what the errors are. So we pass it on to somebody else and they look at it. So there are two faculty that review the stories for us, and they both practice in rural communities, and they're really good at making sure that we're using the right plain language for those communities. Then our project coordinator connects with the rural newspaper editors, and depending on many factors, most of those articles are published in the print edition of the rural newspapers. Sometimes they go into online. I just mentioned that sometimes we don't have good connectivity, but those newspaper editors know their readers and know which articles to put online, which to put in the print edition, and which articles to put in both. So all of those articles are published on the website then, with our partner, the North Dakota Rural Health Association, a really strategic partner here, and Dave's going to make a reference about that.
But each of the states actually has a rural health association at a state level. And so one of the ideas, and I'm a past president of the National Rural Health Association, was to see if we could replicate this and perhaps continue to empower state rural health associations to be able to have these libraries essentially that we could share across the country and potentially someday even internationally.
Yeah. So student participation. Well, we started the project in 2017, and the project has grown. We feel like participation is at least stable, but this last year has been pretty amazing because we've had more and more students join it electively. Our students who are on the rural longitudinal curriculum called ROME, Regional Opportunities in Medical Education in North Dakota, it's been made mandatory as part of their curriculum, and that's usually a cohort of 10. But by word of mouth and by just, I think, interest when they attend some rural health interest groups, they'll hear about the project and they sign up, they want to do it. So it's really fun to have both groups engage in this project. So
keeping in mind we're a small community-based medical school of about 70 students in our class.
Yeah. So we are not privy to rural newspaper viewership data, But we do have some data from that North Dakota Rural Health Association website. And we were kind of surprised when we started to look at that to find out how many views year over year, the last couple of years, and kind of just checking seasonal, because, you know, there are times in North Dakota that some people don't look at anything because they're out in the fields or out in the oil fields. So we noticed that still, you know, 4,500 to 5,500 views on that particular page. We were surprised to find that. And we don't have the resources to analyze that further, but we've postulated 3 different things. First, when we notify the students, hey, your story's live now on that North Dakota Rural Health Association site, we think they're sharing the link with their families and their friends. But because these are publications that are considered somewhat gray literature, we encourage them to put them on their CVs. So then when those students are applying for residencies, we are thinking some of those clicks are coming from residency review committee members who are looking into those, because the feedback we get from students is sometimes they're queried about those stories. And so we're excited about that. And the third reason maybe there's some hits on this is maybe just random internet searches lead them to that site. So, but another data point we'd like to highlight is the individual story viewership data. An average of about 40, but a range of 5 to nearly 380. And we really think that's pretty respectable viewership data. Okay, so stakeholders. We are committed to familiarizing our students with health literacy and plain language concepts. And the majority of the survey results that we get from the students show that the students would do the project again. And to us, that provides some validation that we're doing something right. However, the ultimate stakeholder is our community members, our rural readers. And we don't have the resources to work with the rural newspaper editors to survey their readers, but we ask the editors themselves, can you be the surrogate voice for your readers? And when we went to the Rome site editors, they all told us that the community feedback to them is, why aren't you publishing more of these? So we feel that that's pretty important feedback. And for any of you who are interested in some specific feedback from either our students or those rural newspaper editors, we've got a 7-minute video link here posted. On to replication.
And so as you can imagine, we're a small community-based medical school with really a mission towards primary care and rural health access. And so this has been a very nice project with regard to our students being engaged and being able to really, when they're looking at advancing in their career to residencies, to be able to talk about not only having spent time being educated in a rural environment, but also be engaged with the community around that community's priorities, and then being able to translate that into something that's usable and actionable information. So we would love to share this project. Again, we're a public-based medical school, and we would love to see other health professionals that would want to reach out to us. We don't all have a Kay Miller Temple with regard to plain language, but we think that this is a really important innovation within education and health professional education to make this a priority once again. And hopefully this is a demonstration project that, again, we could collaborate to at least tell you how far down the path we've gotten. We have had some interest from other medical schools and potentially state rural health associations, again, to be able to look at this as an effective community engagement project and an effective education tool that frankly can last the generation of a physician, not only communicating in plain language and writing, but also how does that translate to the physician's effectiveness in the examination room or next to the hospital bed. That's really the goal of our process. So we'll go ahead and share our resources here. We'll thank you in advance. On the next slide, we'll share our contacts, and we'll move on to the next presentation before the group Q&A. Thank you.
Thanks.
Thank you so much, Kay and David. As a former medical educator, I truly appreciate you all sharing this work with us, and I truly hope that we can find additional health professional educators who are able and willing to replicate these efforts, because these skills are so important to all health professionals, so that we can make sure that the information getting out is a way that we can understand. The next up, we're going to focus on the national class standards, or the national standards for culturally and linguistically appropriate services services in health and healthcare, which is why we call them the National Class Standards. But before I hand it over to Leandra, we wanted just to pause a moment. And for those of us who were here yesterday, or if you were tuning in yesterday, if you're online, you saw a number of the different directors of Office of Minority Health. But we just wanted to highlight this because frequently, sometimes we get a little, people approach our office thinking that we're a different Office of Minority Health, and probably vice versa. So just to help orient, there are all of these agencies within the Department of Health and Human Services have offices of minority health. So AHRQ, CDC, CMS, FDA, HRSA, OMH, within the Department of Health, that's within the Office of the Secretary, the assistant, both. They're way up there. And then HRSA as well, and the Institute and NIH, as well as SAMHSA. So with that, I will now hand things over to Leandra. Thank you. You're welcome.
Hi, good afternoon, everyone. I'm Leandra Olson, and I'm the policy team lead within the HHS Office of Minority Health. So as Darcy just said, our office works hand in hand with all of the other offices of minority health across the department to help address health disparities and achieve health equity, working hand in hand. So today I'm going to focus on the national class standards and how OMH supports their adoption and implementation. And you really get to see my coordination in real time because I'm flipping notes and changing slides at the same time. So wish me luck. So culturally and linguistically appropriate services, what are they? We refer to them as class. And the definition that we use in OMH is up on the screen here. And it is services that are respectful of and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication needs. And these are employed by all members of an organization, regardless of size, at any point of contact. So there are 2 points that I want to highlight in our definition at OMH. And the first is how the definition really focuses on the individual. So an individual's beliefs, preferences, health literacy levels, and communication needs should shape how we think about and how we deliver services rather than just a one-size-fits-all approach. And second, class doesn't apply just to doctors or clinical settings, but it should be applied by everyone at an organization at all levels, and by any organization or system that can have an impact on health and well-being. So to operationalize class, the HHS Office of Minority Health developed the National Class Standards, which are a set of 15 action steps that provide a blueprint to implement culturally and linguistically appropriate services to help advance health equity, improve quality of services and care, and reduce disparities. So there are 15 standards in the National Class Standards, and each of which is an important action step that supports professionals and organizations in providing services that are respectful of, understandable, effective, and equitable. And we promote collective adoption of all of the standards, and all of them are seen as being equally important in the framework. The standards are structured to include a principal standard that serves as the foundation for all of the other standards, and the rest of the standards are grouped into 3 themes. I have the principal standard up on the screen here, and I will read it off. It reads as provide effective, equitable, understandable, respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Okay. The rest of the standards fall under 3 themes. So standards 2 through 4 focus on governance, leadership, and workforce. And these standards really emphasize that implementing class is the responsibility of the entire health system, and that it requires the investment, support, and training of individuals within an organization. Standards 5 through 8 focus on communication and language assistance. And this encompasses all communication needs and services. That includes languages other than English, sign language, Braille, oral interpretation, and written translations. Standards 9 through 15 focus on the engagement, continuous improvement, and accountability. And these focus on the supports necessary for adoption, implementation, and maintenance of culturally and linguistically appropriate services and policies. So you can see that the national class standards go far beyond just language assistance. They aim to provide a comprehensive and systems-wide approach that takes into account the wide range of actions needed to fully implement and sustain class. So if I haven't convinced you about the importance of class yet, I'll highlight a few more reasons, which are noted here on this slide, and I'll walk through. My office, the HHS Office of Minority Health, recently sponsored an evaluation project to better understand how healthcare organizations use the national class standards and why they implement them. And they reported that among staff, they implemented the standards to improve cultural competency, language services use, and then quality of services. And then thereby, these would increase client satisfaction, engagement, and experience. They also reported that implementation of the national class standards resulted in outcomes like improved language assistance services, which then improved communications with their populations served, increased organizational capacity to provide services to more individuals, and then better patient access to the organization, more staff diversity, greater regulatory and legal compliance. Okay, so how does the HHS Office of Minority Health implement class? So first and foremost, we developed the national class standards and we continue to promote them. We offer resources that support implementing the standards, including our implementation checklist, our blueprint for advancing class policies and practices, and then our behavioral health implementation guide. And both of these describe concrete strategies aligned with the standards. We also have an evaluation toolkit to support implementation assessment. Secondly, we incorporated an OMH grant initiatives. We ask all OMH grantees to implement the national class standards to help ensure that they're applying a comprehensive, culturally centered approach in their grant activities. Then lastly, we support capacity building through our Think Cultural Health website, which houses resources like guides and e-learning programs for individuals and organizations to build capacity around understanding class. So to dive a little bit more into our Think Cultural Health website, which is thinkculturalhealth.hhs.gov, we do offer a suite of e-learning programs for several types of health professionals noted here on the slide, including maternal health providers, behavioral health providers, community health workers, emergency response personnel, just to name a few. And these e-learning programs are all grounded in the national class standards. They are designed to equip health professionals to serve individuals, diverse individuals, and improve the quality of care. And the e-learning programs are interactive and self-paced, and most importantly, they are accredited. So you can earn continuing education units if you take the trainings. So to close out my portion of the presentation, I do invite you to visit the Think Cultural Health website and check out our e-learning programs and resources and share those with your partners to help promote the national class standards and class in general. So without further ado, thank you very much. I really appreciate you listening to me, and I'm going to turn it over to my esteemed colleague, Darcy Graves.
Thank you, Leandra. I've had the pleasure of working with Leandra for over a year now, but this is the first time I've met her in 3 dimensions. So, we're looking for the CMS class standards slides. Maybe this didn't happen. I can ad lib. Okay, that's fine. So just bear with us, and we're just going to talk. We're just going to adapt. We're just going to roll because that's what we do when we work in culturally and linguistically appropriate services. Sometimes we have the resources. Sometimes we don't. Sometimes we have the people. Sometimes we don't. But you know what? We always have the passion. We always have the energy. We always know what is important. Yes, so I'm going to take a few moments to talk to you about CMS and the National Class Standards. And when we think about the National Class Standards, we work to implement them. Oh, look, there I am. See? Thank you, everyone. Okay. So thank you, Leandra, and thank you, tech support in the corner, whose name I don't know. We will build statues in your honor. Okay, So when we think about the implementation of national class standards, we essentially think about them in terms of three buckets, if you will. The first is really thinking about it at an enterprise-wide strategic planning level. The second is to make sure it's embedded across policy, programs, and data. And finally, it's in our engagement efforts and resource development and dissemination. You all have been here for the last 2 days, so I'm not going to belabor all of the things that CMS does, but you know that we touch over 170 million individuals across our 3 programs. And as I already noted, and I'm not going to read these to you, but as we've already noted, we have a framework for health equity. It has 5 priorities. You'll see them throughout the agenda and how things are tied together. And as my panelists have already talked about, we're really kind of focused on priority 4 during the course of this session, but they all have equal import. We have to have the data. We have to assess the causes of disparities. We have to build the capacity of those we serve, just like Kay and David highlighted. And then we need to advance language access, health literacy, and the provision of culturally tailored services, because if individuals can't understand the care, or if the care, it does not resonate with them, then there is an automatic block there. And then priority 5 rounds us out by focusing on the increasing all forms of accessibility to healthcare services and coverage. So we recognize that as an agency, we must understand and implement the national class standards and language access related policies and programs at an enterprise level to ensure that it is part of our strategic thinking and forward planning. I always talk about, when we talk about class, it needs to go from the top down and the bottom up. It can't be located just in the middle of an organization. So to this end, we have been pulling and working on our activities to pull them together so that we have an agency-wide picture of what we're doing across our programs to implement class, and as it ties to the national class standards. As a part of the work, we have an internal advisory council on equity and a policy group called the Health Equity Policy Collaborative that is intimately involved in this. We are also working as an agency to implement and update our CMS language access plan, aligned with updated regulations related to Section 1557 of the Affordable Care Act when they are released later this year. As I already mentioned, we also have the CMS framework for advancing healthcare in rural, tribal, and geographically isolated communities, which is a sister document to the Health Equity Framework, which helps us to operationalize our work across diverse geographies. Because when we're talking about these individuals who are in rural areas or frontier areas or in tribal nations or on island communities, I was in Alaska earlier this month, and we're hearing about people who have to take a plane ride to get their primary care visit. And that same thing is happening to individuals who are on some of the islands of Hawaii, as well as those in our US territories. So all of these pieces are important for us to think about. These agency-wide plans and our agency-wide approach to delivering culturally and linguistically tailored care across all of our programs helps us to align our actions with the department and within CMS to think strategically together to ensure that we are collaborating, working proactively, and ultimately delivering the best, most accessible, and most appropriate care to each person our agency serves. CMS is also taking actions across our programs, so that's Medicare, Medicaid, CHIP, and the federal marketplaces, to ensure that our regulations and requirements promote delivery of culturally and linguistically appropriate care. One significant example of this, released last month or earlier this year, is the 2024 Medicare Advantage and Part D final regulation. This regulation has a number of provisions related to cultural competence. For example, it helps to clarify current rules, expanding the example list of populations that MA organizations must provide services in a culturally incompetent manner. And this includes individuals with limited English proficiency or reading skills, various ethnic, cultural, racial, or religious minorities, people with disabilities, people who identify as lesbian, gay, bisexual, or other diverse sexual orientations, those who identify as transgender, non-binary, and other diverse gender identities, or people who were born intersex. It also includes those who live in rural areas and other areas with high levels of deprivation and otherwise adversely affected by persistent poverty and inequality. In addition, its studies demonstrate low digital health literacy, especially among populations experiencing health disparities, continues to impede telehealth access and worsen care gaps, particularly among older adults. CMS is finalizing requirements for MA organizations to develop and maintain procedures to offer digital health education to enrollees to improve access to medically necessary covered telehealth benefits. And we're also enhancing current best practices by requiring MA organizations to include providers' cultural and linguistic capabilities in provider directories. This change will improve the quality and usability of provider directories, particularly for non-English speakers, those with limited English proficiency, and enrollees who use American Sign Language. We hope that taken together, these provisions significantly strengthen the provision of culturally and linguistically appropriate care among Medicare Advantage plans. We have numerous other examples that relate across so many of our programs. And so, but this is just one key example because I want to keep within the time limits that we all get to go. So, okay. So, and then finally, outside of policy and programs, we have public-facing resources, training modules, educational content, and cool toolkits, and resources for community collaborators and CMS partners that promote delivery of culturally and linguistically tailored services. This slide includes a few examples. In the marketplace, our training for assisters includes a module on delivering culturally and linguistically tailored assister support. So these are the individuals who help individuals enroll in the marketplace as individuals find and enroll in the plan that they find is right for them. Our Medicare Learning Network hosts several trainings free of charge for all healthcare professionals, including those related to promoting delivery of linguistically tailored services and language access to healthcare services, as well as trainings related to ensuring that care meets the needs of individuals with disabilities and members of the LGBTQI+ community. Our office, what we affectionately refer to as our duals office, our office that serves the individuals who are duly enrolled in Medicare and Medicaid, hosts a hub for resources for integrated care with information, resources, and training content that promotes delivery of culturally and linguistically appropriate tailored long-term services and supports and caregiver supports. And from CMS OMH, we have several resources on our quality improvement resources tab of our page, as well as our Coverage to Care initiative, which aims to help healthcare professionals and community partners deliver culturally and linguistically tailored care and communicate at all health literacy levels to all communities. This information helps individuals find care and find, once you have a health insurance card, doesn't mean you know how to use it. So we have a whole set of resources that are tailored to help do that. And many of them are available in 8 to 10 languages. Again, free of charge, can be ordered and used. So, again, thank you so much. Here are the email addresses for our respective offices, mine and Leandra's. We hope that here we are, who can help get your questions to us and can pass it on to the right person if that isn't us. Okay. Up next, we have the community partnerships and data advocacy for cultural and linguistic competence and developmental disabilities. So now I will turn things over to Dr. Hira Mir. Oh, and Regina, I did one at a time. You're both coming, so.
And I'm trying to normalize that.
Hello?
Okay, it's on. There we go.
Hello.
Hi, everyone. So I'm going to start by describing myself to you because that was the instructions that I got. My name is Regina Rodriguez Cecilia. No, I'm kidding. It is Regina Rodriguez Cisneros. It is Cecilia, and I do have Maria in there because I'm Latina. I'm Latina, and I'm also Native American. I'm about 5 feet tall. I have my fan on because I have 9 children who have caused this to happen to me. And I'm wearing my glasses, I have red lipstick, and I'm standing next to my friend Hira. Okay.
And I'm Hira Mir. I am 5'7". I have short black hair. I don't know what glasses I'm wearing. I think they're the cat eye ones today. The rose gold cat eye glasses and black skirt, blue polka dot top.
So I think what you heard today, right, was talking about the CLS standards from a macro level, which is, I don't know if Darcy knows this, but I was geeking out on Darcy. I have been working on the CLAS standards in Colorado for about 15 years. Implementing them and implementing DEI. Anyway, so I'm from Denver, Colorado, but I work for the National Association of Directors for Developmental Disability Services that's here in Alexandria. So I go back and forth. And what I do is I support the directors in the states to actually implement those standards, right? I mean, these standards, understanding the CLAS standards and really trying to figure out, now how am I going to do this? How am I going to execute this in my agency, in my program, in my community? So what I did is I created a tool at NASDS. That's what that long title, shrink it down, it's called NASDS. I created a tool to help organizations to look at, to do a self-assessment and figure out, where am I here? Where is our organization here? Where is our state here in the realm of these CLAS standards, so that they could actually get a number, an indicator of a number that says, you haven't done anything, or you're doing some phenomenal work, so that an organization can now start to develop a strategic plan on how to implement the CLAS standards. Like I said, I really appreciate the CLAS standards because they are a guiding tool that we can use throughout our work and implement and embed DEI so that it actually dismantles strategic racism and strategic processes that are putting barriers in our communities, and also recreate some positive processes that we can utilize to help our communities to receive the services the way they want to be receiving the services. And that's basically what that slide says.
You want to go into?
Yeah, sure. So in order to implement these CLAS standards, it's my soapbox that it is not okay to implement something like a CLAS standards, an assessment, a policy change, without engaging the community, without talking with the community, without assessing the community. I listened earlier to the presentation in the Indian Health across the way there, and there were 9 priorities of how to actually implement the work that they're doing. And I thought to myself, goes for Latinos, that goes for African Americans, that goes for Pakistanis, that goes for all of us, right? These communities need to be engaged at all levels. And I'll also say that Latinos are Native. And I just want to say that what's really important is that what we do with these CLAS standards before we start to implement them and start to engage is that we create safe spaces for communities to show up, safe spaces for a community to show up in pairs so that they don't show up alone, or so that they show up with multiple representation of, we cannot put everybody in Asian American. We cannot put everyone into American Indian. We cannot put everyone into African American. We have a whole spectrum of people that fall into those categories. And so when we engage communities, we should allow, entertain, and invite communities to show up in droves. And that bring a chair movement, we need to bring a couple couches, because Latinos show up that way, right? We go to the grocery store that way. We go to the grocery store with the whole family. So we have to make sure that we bring several chairs, because we have to recognize that a Latino who is first generation has a very different perspective than a Latino like my family, who's been in Colorado for 7 generations. We have different perspectives, right?
So I work at the New York State Office for People with Developmental Disabilities. It is actually the second largest executive agency in New York State, and we provide Medicaid services to over 128,000 New Yorkers with developmental disabilities. That includes people with cerebral palsy, autism, spectrum disorders, Down syndrome, intellectual disabilities, developmental disabilities, and other developmental disabilities that we call DD. I think one of the first things is, where to get started. we were lucky in New York State and OPWDD that we joined with many university centers, our Disability Rights Council, our Developmental Disabilities Planning Council, and just 2 multicultural providers, one who served Chinese American families with developmental disabilities, and another provider who serves Spanish-speaking families with developmental disabilities. So just to get started, in 2017, we created a community of practice for cultural linguistic competence. It was sponsored by Georgetown University's National Center for Cultural Competence. And so that was going on since 2017. We started with doing focus groups, listening sessions, just focusing on those 2 communities, those who speak Spanish and have developmental disabilities, and those who speak Mandarin and have developmental disabilities. And that's because those are the top 2 spoken languages in New York State after English. And just, that's 2017, the community of practice sustained itself. And it wasn't until last year that OPWDD hired me as its first chief diversity officer, and also created the executive office of diversity, equity, and inclusion. And so that goes to tell you that you could have a community of practice, you could have, an excellent model, but it can still take years for a state agency to really implement and start, doing things around staffing, policies and practices. And so with that, we were able to become a strategic partner in 2 really incredible pilots. One pilot is called the Ensuring Access Grant, which is us redesigning our entire front door information system. It's the way in which people understand what services OPWDD offers, redesigning them into writing the scripts for those sessions in Spanish and in simplified Chinese, and having, paying our community members to do voiceovers of our sessions. And so that is just a pilot that we started. I think it's around $500,000 or so that's funded through this community of practice. And that's one incredible pilot, again, that just started 2 years ago. And that just as a place to start. So focusing on just those 2 communities, taking a look at the top 10 and what are the two top. So I'm very practical. So I'm going to give you like real practical ways in which we've just gotten started. And again, my role as chief diversity officer is then how do we expand this model? How do we scale this model? Because we have so many languages. Additionally, when you're talking about people with developmental disabilities, our data is showing that 40% or so don't have a spoken language at all. They rely on American Sign Language, other forms of sign languages, nonverbal languages. And so just really making those considerations in the design of our materials and how we're sharing information.
Awesome. So I hope you're kind of seeing, as we're going from the macro to the association level of providing technical assistance and really helping states to tangibly start executing the CLAS standards and making changes. One of the things that's really important to do to move the needle in all of these processes is to collect data, right? We have to have data. But data is only as good as the person who's reading it. That data is going to be interpreted by several different people, and it's going to be analyzed in several different ways. My soapbox for data and providing technical assistance for states is to engage communities at the development of your methodology, not later when you have an invitation to come and participate in a survey, but to actually engage communities in the collection of data. And the reason that I say that is because it's really important to understand that injustices have been impacted in many, many communities. That creates a barrier that may or may not be visible to a healthcare provider, a government employee, somebody who's coming in and trying to provide services. We need the community to be able to say, that question looks really good on paper. However, that question is going to offend 75% of the people that you ask, and you're never going to get a response. Or you're going to get a fake response, right? Because I'm protecting my family, I'm protecting any type of injustice that may come to me or my family or my community. So engaging communities in analyzing that data so they can help you to understand why maybe there's a historical perspective and why that data has an influence marker in there, right? But then also creating an investment and their engagement to that data and to that survey so that when we're ready to start coming up with some ideas on what we're going to do with whatever disparities being addressed, communities know the answers. Communities are intelligent. Communities need plain language, I agree. However, communities need health literacy so that we can understand the language that's never going to go away. Health language is never going to go away. Don't dummy down, engage, empower, and teach our communities and bring them to the tables. They also have the ability, they have the infrastructures. Communities, underserved communities, have the infrastructures to survive. So if we start working with those communities, we can actually start putting the money in the community resources centers, empowering the people who already know, who already have the connection to the families, and ensuring that we have the champions in place so that when we come around with pilot projects or we come around with surveys, our relationship is built.
I would say the kind of one other like practical implications in New York State is, one of the main things that we've heard from several minoritized communities is we deserve to be seen and we deserve to see ourselves in your government reports and on your websites. So in 2019, we had some advocacy. A bill was drafted. It actually didn't make it into law. And it was the Asian American Data Disaggregation Act. And it didn't, pass under that governor, but under Governor Hochul, we do have a new law, which is the Asian American Pacific Islander Data Disaggregation Act. And it basically mandates that any state agency, any executive state agency who receives state funding, if they ask for data asks you to identify as Asian and you identify as Asian, then that state entity also has to make it so that you, the Asian category is then further delineated into other categories, the top 10 up to 14, as demonstrated in the United States Census. It also mandates data reporting on language based on the census, but also reporting out. So after you collect data, then publishing the data on your constituents on your website. So again, I think we're lucky right now in New York State that we have these mandates, and we're really trying to work quickly under the current administration to put these into legislation, but just mandating data collection throughout your systems, and then hopefully waiting for CMS to also accept those same data categories so that the state systems and the federal reporting systems can be aligned. So in talking about strategies, I feel that strategies are most impacted when we start to incorporate the CLAS standards into our policies and processes. So what I did is there's 15 standards, right? And I took those 15 standards and I have one policy specific to each standard that I can use either to require that they be developed into processes and procedures within an agency, and or the majority of the work that happens from state agencies are not done by state employees. More often than not, it's contracted out, right? It's contracted out to direct service workers. Those 15 policies that align specifically with the CLAS standards can now be appendix in your contract. And now we hold accountable the direct service providers, the contractors, the people that are receiving our civil dollars, our fiscal dollars, hold them to the same standard that we have of health equity and start requiring that CLAS standards are implemented into the work that we're delivering every day. So I'm not there yet in my work as Chief Diversity Officer to have a policy for each class standard, but what we did, I've been in my position for 10 months. One of the first things that I did is I met with our counsel's office. They published our regulatory agenda, so the policies and regulations that go out to govern our nonprofit Medicaid providers. We have a network of approximately 600 nonprofit Medicaid providers, and so I added language access to our regulatory agenda. I engaged with they reached out and said, "You're the Chief Diversity Officer, what are you doing for us?" A small provider who serves predominantly deaf or hard of hearing persons and families and staff with developmental disabilities. And so they said, these are the gaps that we're seeing. And these are the ways in which providers and state agencies are not meeting our needs. They're exploring these loopholes and these flexibilities in the civil rights law, in the New York State language access law. So I added language access to our agency's regulatory agenda. I met with counsel's office, who has been a great support, and then walked me through the regulations, New York State law, what happens when you do an amendment. There's a public comment period. And we actually, started meeting with our partners, just kind of casually, informally, to say, this is the New York State regulation, how might we strengthen it? So in an area where it says interpretation and translations have to be provided in a timely manner, timely wasn't defined. And so we actually started defining timely. In a place where it said, spoken languages, we made sure that it said non-spoken languages, and things like that. So that hasn't been released yet. It's going to be released for public comment. It could take forever. And then, after that regulation, we're going to, there's plans to publish the agency's first policy, outward-facing policy for language access. And I've been told by other incredible deputy commissioners who do this type of work that it could take anywhere from 1 to 10 years to put a policy like that in place. But it would be the first language access policy that we have at OPWDD, which I mentioned is the state's second largest New York State agency. So that would be incredible. And it could take, 10 years, but it's a place to start.
Well, since we may have 1 to 10 years, I would, and Harriet doesn't know this yet, so we have to have a conversation after. But I would really challenge New York to add transcreation into their translation or any linguistic accommodations that happen. And transcreation, if you don't know, is really making sure that we don't translate word for word, that we recognize that concepts are not, we have to engage the communities to really understand the concepts specific to health literacy. If you're translating word for word, you're losing a lot of the information, and or many communities don't have any of the Western health language that we have in the United States. So I think we're at time, right? Thank you, everyone. If you have any questions, reach out.
So we are at time, but I just want to say thank you